Yes.
Good afternoon, Dr. Entwistle.
Hello.
Just a couple of points to pick up from this morning's session. First of all, just to make a correction, I was showing you the forms before lunch and suggested that I hadn't found a form between 1965 and 1985. It's been pointed out to me that we do have a form from 1977. I don't think we need to go to it, but just to correct the transcript, the URN for that is DHSC 303734_066, and it was pointed out to me that Dr. Napier was taken to that form. The other second point I just wanted to pick up before I ask you about arrangements in Oxford for HIV testing was just a follow-up question really from the question that Sir Brian put to you before we broke for lunch, and that was to just ask you what your relationship was like with the Regional Health Authority, what the communications were like and how often you met and so on.
Well, not so much with the RMO's Regional Medical Officer, but with the others in the Health Authority, communication was pretty regular and a very good relation with HR and with the gentleman who was overseeing the blood transfusion service.
And we were looking earlier at a circular, and you thought that hadn't made its way to you. You certainly couldn't recall seeing it. Was the Health Authority fairly good at disseminating information to you that they had that you ought to see, or was it or were they not so reliable?
I don't think I'm in a position to comment on that. I think one of the big problems one might be up against, as I'm sure you must have found too, is that sometimes when you get a massive document, it's awfully easy to overlook a paragraph.
So turning then to the arrangements in Oxford for HIV testing, can we turn first please to NHBT 304521. So this is NHBT 304251.
I think we may be drawing a blank on that one.
Yes, okay. Perhaps I can deal with this without going to the documents. We'll see how we do. Maybe we can come back to it if we don't get very far. So is this right, that initially when you were being asked, when planning for HTLV3 testing was being undertaken, the initial view from your centre, from you and your centre, was that you would need to do some building work before you would be able to start screening donations for HTLV3. Is that right?
That was our original thought. However, because it was apparent, very readily apparent, that the rest of the centres were all going to start screening as from, I think it was the middle of October of '85, we had a duty of obligation to get going by that date. So we had a radical rethink of the arrangements in our microbiology section of the laboratory, and we were actually able to start HIV screening on time.
And so, and the reason you were able to do that, because as you say, you had a radical rethink and you reorganised the space, did you?
Yes.
And did you ever get your building work?
No, we didn't do that. Our original thoughts would possibly take over part of the store, which was next door, but in the end that was not necessary, thank goodness.
Then let's try this document. DHSC 40177. Yeah, so this is AIDS booklet 2, information for doctors concerning the introduction of HTLV 3 antibody tests, and from dated October 1985. And if we turn over the page, we can see that this is a letter to all doctors in England from, and if we turn over to page 3, we can see that it's from Dr. Aitchison, the Chief Medical Officer. And I just want to ask you about, if we turn back please to page 2, I just want to ask you about what arrangements were in place in Oxford when HTLV3 screening was brought in. So we can see that it says at the beginning of this a letter that from a date in mid-October, second paragraph, all to be announced, all blood donations will be screened, and that at the same time, alternative facilities for providing antibody tests on a confidential basis will become available at GUM clinics and by arrangement with the patient's general practitioner at certain other clinics as arranged and published by the District Health Authority. Now, we've heard and seen evidence that the concern, there was a concern on the part of the regional transfusion directors that there should be alternative venues for screening so as to avoid high-risk donors coming to donate in order to get an HTLV3 screening test. Is that right?
Certainly, we did not want high-risk donors coming in just to have the benefit of the test.
So can you recall whether when you started screening in Oxford, there were these alternative arrangements for those that wanted to get an HTLV3 test to go and have one?
I understood that they were actually in place, yes.
And then we go down to the bottom of that second page even. It is essential that all individuals who are found to have positive antibody tests receive counselling, both in order that they understand the meaning of the results and to advise them of how to avoid transmitting the infection to others. And then if we go over to page 11, we see under counselling, it says within GUM sexually transmitted disease clinics, multidisciplinary collaboration involving social workers, clinical psychologists and health advisors is usually available to assist the proper counselling and support of AIDS sufferers and their contacts. Support is also available from some community-based groups, and then details are provided. So just on the question of counselling, what counselling arrangements were in place and were the donors who tested positive able to access?
Well, I personally was only involved in one came, and in fact I was the person who initiated counselling. I arranged to meet the lady who lived in Reading, and I met her in the Royal Berks Hospital and explained the situation as best I could. I had the benefit of going to a meeting in St Mary's, Paddington, on how to counsel patients who might have HIV. And I was able to sort out the probable mode of acquisition of her infection and point her in the direction of her GP, who might then point her further for appropriate further management and possible treatment, bearing in mind that at that stage there was no specific treatment available for HIV.
So it wasn't, and I appreciate you're talking about the practice of counselling one individual, but as far as you, that there wasn't a practice of trying to access these multidisciplinary type team approaches of counselling for donors.
No, we were not involved in that at all.
And then if we can just go to page 8 of this document to look at the confidentiality provisions. The strictest confidentiality must be maintained when an HTLV3 antibody positive individual is identified, where a person is tested for HTLV3 infection or for its complications and it is thought to have been sexually transmitted. Health authorities have an obligation to maintain confidentiality of information under the terms of the National Health Service Venereal Diseases Regulations. Unless the patient has given his consent, personal health data relating to him must not be disclosed to anyone for any purpose other than the healthcare of that patient, except where the disclosure is necessary to prevent the spread of infection. Disclosure of this information for purposes other than medical or public health reasons could lead to serious consequences for the informant. Adequate safeguards to protect individuals against unauthorised disclosure must be adopted. So one could read that as suggesting that there might be two different levels of confidentiality in relation to the results of a HTLV3 test, depending on how the person became infected. But is that the way that it was read by you and your colleagues at Oxford, or were all donors treated in the same way in terms of confidentiality?
As far as I'm aware, pardon me, as far as I'm aware, they're all treated the same way, but confidentiality was maintained in that no information was passed on to anybody except with the specific consent of the individual concerned.
And that would include, would it, passing on test results to GPs or to other clinicians for further treatment?
Indeed.
And would that also include passing on information to family members or partners of the donor, infected donor?
We would not do that, but obviously we would stress to the individual concerned that they would be the ones to pass on the information as appropriate. But certainly we did not feel that it was either our obligation to pass it on, nor should we pass it on.
Moving on then to a slightly different HIV-related topic, if I can put it that way. If we could have, please, NHBT 20092851. If we could go, please, to page 2 of this document. We can see that this is the minutes of a Western Division of the MBTS Consultants meeting of the 4th of October 1985, and we can see third down that you were present at that meeting. If we could go to the bottom, please, of this page, we see at paragraph C, it was agreed that absolute confidentiality should apply to donors found to be HTLV3 antibody positive. A proposal from Dr. Moss, consultant in GUM, that GUM specialists be notified was not accepted, so that bears out what the evidence you just gave us. And then it's E that I wanted to ask you questions about. AIDS update. It was accepted that there would be substantial amounts of untested, long-life, frozen components in circulation, mainly in hospitals, at the time of the general announcement on testing. Centres were operating different policies for the use of this material. Over the page, testing of frozen stored red cells was also considered. It might have to be accepted that current stocks cannot be tested. Many donations were in fact collected before the prevailing epidemic. The washing and reconstitution might also reduce the risk of virus transmission. New donations obtained from past contributors could be tested, and when found negative, their preceding donations be certified as being safe. Now, just with that prompt, if I can put it that way, can you recall what the practice was in the Oxford Centre for any stocks that the centre had themselves that had been harvested prior to testing that might perhaps, for example, be frozen, what the practice, whether or not those were released post the testing date as untested components or products.
Well, we had no frozen red cells at all, so that can be forgotten about. I can't recall offhand what other products you might be thinking of.
Well, would you have, for example, what long life products with a long shelf life was the centre? Would the centre or could the centre have been holding in October 1985?
Yeah, there could have been fresh frozen plasma, which would have been in store, yes. And that's all I think that we would have held.
So can you recall whether you tested that fresh frozen plasma and then released it, or whether you would have released it post 7th of October 1985, despite the fact that it was untested, because it had been collected before that date?
I see what you're getting at, and I can't recall exactly what did happen. It would have been nice to have withdrawn it or tested, which we couldn't do anyway. But I suspect, I may be proved wrong, but I suspect it would have been issued.
And
even though it had not been tested, it would have been collected before introduction of testing.
And when you say you couldn't have tested it anyway, why was that?
Because we would not have had separate samples from that frozen plasma.
So you would have had to test the whole batch?
Indeed.
And would that not have been possible?
Not really. I think we'd probably have to have abandoned any frozen stocks.
And then turning to the stocks that were in hospital, which was given specific regard in the meeting minute we just looked at. So the expectation of the Western Division was that there would be, at the time that testing came in, substantial amounts of untested long-life frozen components in circulation. Can you recall what the practice was at Oxford in terms of that material? Do you think Oxford recalled those products and tested them and then released them, or do you think they were left in circulation to be used post-testing but as untested products?
I can't recall, but I suspect they would have been issued in the normal way, even though they had not been tested prior to screening.
So you can't recall, but you think it's likely that there would have been some products both issued by the Blood Transfusion Centre and issued by the hospital blood banks after the date in which testing for HTLV3 came in, and those products would have been untested. Is that a fair summary of your evidence?
It would be untested, yes.
Can we then turn, please, to NHBT 20196330_003? Now this, I wonder if you can first of all help us to understand what this document is and how it came into being. We can see it's a witness statement from you, and it goes over several pages, and then if we go please to page 7, we can see the date of it, 4th of January 1990. Can you remember what this witness statement was produced for, why it was produced?
I have no recollection what that was for.
So if the paragraph I wanted to take you to starts at page 6. You talk there about testing, and then in the second and third paragraph you talk about counselling, and then it's at the end of the last paragraph I want to pick up. It starts about halfway down there. Should a donor become HIV infected, halfway through the line, should a donor is halfway along the line. Should a donor become HIV infected, the corresponding antibody does not develop and become detectable until after a time lag, which varies from a few weeks to perhaps several months. The risk of a donor giving blood during such a time lag or window of infection has been calculated to be in the order of about 1 in a million, that risk being less in the UK than some other countries who accept donations more than twice a year from the average donor. Consequently, if a donor were to become infected, there is a good chance of there being only one previous, possibly virus-containing plasma donation, which would be most probably still held in quarantine anywhere before being pooled and fractionated. And then we'll go on to look at the situation in relation to plasmapheresis donors. But just pausing there, was it the practice of Oxford to keep back donations of new donors until a second HDLV3 test had been carried out to guard against the risk of them donating during that window period?
Not as I recall, and I don't recall any recommendation coming that we should have done either.
And so that presumably would be both in relation to new donors and in relation to established donors. There was no policy. And then if we pick up then where we left off at that document and look at the situation with relation to plasmapheresis donors, the situation could potentially be slightly different in respect to donations given by pheresis in view of the much greater frequency of donation and also in view of the rapidly expanding role of pheresis in meeting plasma demand. And so then you go on to say what the new code of practice says in relation to frequency of donation. And you say there in Oxford, most of our approximately 400 pheresis donors panel donors arranged to come monthly. Although this frequency of donations could be a possible problem if a donor were to become infected, safeguards are provided by our knowing the donors concerned very well, by undertaking rather more rigorous health checks on them before embarking on pheresis and at regular intervals thereafter, by routinely screening every donation and by keeping their donations in quarantine, frozen, both at the centre prior to shipping to BPL and for several months at BPL before fractionation. Although we have no proof for our impression, we believe that pheresis donations may possible, if anything, constitute a lesser risk from HIV window infection of plasma for fractionation than conventional donations. So looking at that, does that accord with your recollection that there was a different system for pheresis donations and that you kept donations in quarantine until another test effectively had been taken to guard against the risk of a donation being taken during the window period?
Yes, that's a fair comment. The risk we felt would be significantly less.
What was the position in Oxford in relation to products such as platelets, which needed to be used within a few hours of the donation being taken? Was it possible to always test the platelets for HDLV3?
Yes, because the platelets would be collected on day 0. The test would be done first thing next morning or even that same afternoon at day 0, and they would be available for issue after testing had been completed. There's a window of using platelets for up to 3 days, possibly more.
Was there any practice of putting warning labels or providing any kind of warning on products that for example, the blood or the product may still contain viruses because of this risk of donations being made in the window period? Because clinicians would be expecting, wouldn't they, post HTLV3 testing coming in, that the product would be free from HTLV3. But in fact, there remained a risk, didn't there, that the product may still contain HTLV3.
There remained an exquisitely small risk, yes, but I don't think any such warning was ever put onto the product itself.
Can I ask, can we turn to a document just to get your evidence as to whether or not you were aware of this document, and if so, what you understood it to mean? It's the, it's, if I can find it, SHPL 40163_033. It's the WHO Expert Committee on Biological Standardization 29th report, and the date in the bottom is not very clear, 1978. I think it says 8, yes. And then if we turn over to the second page, sorry, we get the more detailed title of the report. Which is requirements for the collection, processing and quality control of human blood and blood products. And then if we can turn please over to page 18. The particular bit I wanted to ask you about is on the right-hand side, B3.6. Sorry, can we go over to page, yes, the next page. No, no. Perhaps we'll come back to that. We seem to be having a little difficulty with getting that page up. I mean, what I can ask you, the general question: was that a publication that you were aware of and that was something that you were familiar with?
No, I can't recall having ever seen that before until a copy was sent to me recently.
Can we try this document then? PRSE 301355. We've got an original transfusion directors meeting with you in attendance on the 20th of January 1988. And if we can turn please to page 6 of that document. We can see halfway down a title, Package Insert from Platelets. Dr. Entwistle questioned the need to provide a package insert for platelet preparations. Discussions on this centred on the need for up-to-date notes on transfusion, to which a general package insert might refer, and appropriate training of staff. It was recalled that at the product liability meeting, Mr. Evans, solicitor, had pointed out that it was also necessary to anticipate what people may do wrong. The chairman asked Dr. Moore to approach the DHSS solicitors for further advice. Can you recall what this was about and why you were questioning the need to provide a package insert?
At this time, I can't recall what that was about. I'm sorry.
Do you think could it have been in order to warn of interdictions or risks of platelets coming in relation to platelets?
Well, there are two questions which emerge. I thought you were asking about, could he recall why he was questioning the need for the insert? Your question now seems to be what an insert might have been there to do.
Yes.
I think we may take it that a package insert will say whatever a package insert says. If Dr. Entwistle can't remember, then I don't think he can probably help us further on this.
Okay, thank you, sir. Can we then... I've got a handful more questions to ask you in relation to HIV. So can we turn now to BPLL 001 0773? So this is a letter from you to Dr. Snape, dated 13th of January 1986, and you're answering various questions that have been put to you. Paragraph 1, you explain that donations at Oxford were tested from the 7th of October 1985, and then you say this at paragraph 3, retrospective investigation of any positives that turn up will obviously be pursued up to 6 years if possible. So I just wanted to ask you about the systems in place in Oxford for effectively look back. So when a donor tested positive, what action was taken by Oxford to investigate whether any previous donations had been used by patients? So was there a system in place for carrying out those investigations?
There was what I can best describe as an ad hoc system, insofar as this was not a regular routine activity. On the other hand, obviously when a positive case turned up, it would be necessary to go back and see what we can find by way of further information about that same donor.
And do you know what the reference to 6 years, why you were limiting it to going back 6 years?
I was puzzled when I saw that this last few weeks. And I can only imagine it's because it was a general feeling that there was no risk of HIV in this country prior to about 6 years before the testing was started. In other words, the late 70s.
And do you recall whether, as part of the retrospective investigations, you would have taken steps to try and ensure that the eventual recipient of any donation was informed that they may have HDRV3?
That is an obvious corollary where there was a positive, but I don't recall there ever being one.
And equally, would the retrospective investigations have included informing BPL or PFL that they had received infected or potentially infected donations?
I think it is something which they would need to know about in case they still had material in the system.
So that's something they should have known about. Can you recall whether or not that's something they were told about?
No, I can't offhand, I'm sorry.
And were there any circumstances, or do you have any recollection of whether or not information would have been provided to the Haemophilia Centre about the fate of any infected donations?
Well, no, I don't recall any such information being passed on.
And then just a further document on HIV look back, NHBT 001 5108. It's a letter from Dr. Gunson to all RTDs saying he's been asked by the Department of Health to contact you with respect to the identification of any possible blood donations which may be implicated in transmitting HIV to patients as a result of blood transfusion. Could you please identify the blood donors that you have found to be confirmed HIV antibody positive since the commencement of testing, and send a list of the donation numbers of the previous donations, if any, from these donors, together with dates of delivery to the consultant haematologist at the hospital concerned. Some of you already may have this information available from look-back programmes. And Department of Health's anxious, no potential beneficiaries are overlooked. So this is some 6 years later than the letter we saw from you to Terry Snape, and you're being asked by Dr. Gunson to carry out look back. Can you recall what action was taken as a result of this letter?
Frankly, no, I can't.
And then last issue in relation to HIV, can we look please at NHBT 0019630_003? So this is the witness statement that we looked at earlier. And if we can turn please to page 3 of that document. The second and third paragraphs, you're talking about the stockpile of plasma that had built up at BPL as a result of the rebuilding of BPL and the reduction in their ability to fractionate. And it's the third paragraph, I want to pick it up. You say at the beginning of that paragraph that the problem with having the stockpile was that the HTLV3 testing came in. And the stockpile was untested. And you say the stockpile was affectionately referred to as the iceberg. And then you go on to say this: all centres had to examine the records of all donations sequestered in the iceberg to see whether their corresponding donors had donated blood more recently, had been screened and had perhaps proved positive for HIV-1. In Oxford, we traced about 2/3 of the many thousands of donors concerned, and were able to confirm that they had subsequently been bled, tested and were found clear. We understood that the remaining donations from donors for whom no further information was available could not be used and have not been processed. So is it right to understand that the 2/3 of the donors that you did find, that was because they had subsequently come back to the centre to donate and their donations had been tested because HTLV3 screening had been introduced by that stage?
That was my understanding, yes.
And then the third that you couldn't identify, that was because they hadn't returned to the centre to donate, and so there were no tested donations for that
Yes,
third.
that's correct.
And were any steps taken to try and get in touch with that cohort of donors to see whether or not they would be willing to come back to the centre and have their...
Not that I'm aware of.
I'm going to pick up now then with HCV and hepatitis C look first at a document from October 1990, NHBT 009472_050. Now we've looked at we looked at some documents last week with the witnesses that gave oral evidence last week, and I don't intend to put to you the same documents that they looked at, but I just wanted to show you a handful of documents to get your evidence on what you can recall about your thinking at the time. So it's NHBT 009472_050. No, okay. Let me come back to that if we have better luck with the system in relation to that one. Can we try this letter, this document, NHBT 5074_030. Yes. Okay, so this is a letter that you wrote on the 9th of May 1991 to Dr. Lloyd from the Northern Newcastle Transfusion Centre. And we've heard evidence that Dr. Lloyd began testing at his centre prior to the date that had been set for all regional transfusion centres to begin their HCV testing. It's a response to a letter from Dr. Lloyd informing regional transfusion directors of his plans. We've looked at it before, so I don't intend to go to it now, but for the transcript, it's NHBT 5073_014. And this is your response to that letter. We can see here that you say, I'm utterly dismayed at your proposal to break ranks from the rest of the BTS of England and Wales by embarking on HCV testing in the way you've described. I know you already realise that we have a national directorate who have striven hard to try and generate some cohesion into our service, and your proposal can be viewed as nothing less than destructive when other centres are aiming to introduce their testing not so long afterwards. I would have thought common sense would have indicated that we should all introduce testing for this reagent from the same agreed date. I would fervently ask you to reconsider. So if I can just ask you some questions about your thinking in the light up to writing this letter. We've heard evidence that the UK was introduced testing rather later than a lot of other developed countries. Was that something that you were aware of at this time?
I know that countries were introducing it at different rates, but on the other hand, that is not surprising, because they all have different resources available at their disposal. But I was very firmly of the opinion, as you'll gather from this letter, that having got a national directorate with its own policy for the service as a whole, that we should follow the directorate's policy and not break ranks in this way. It could be argued that Dr. Lloyd was providing the additional benefit of having some extra donations screened before, whereas others not. But on the other hand, I still think that the tone of that letter was right, that it should have been done as from the agreed date.
And would you accept that by introducing screening for HCV earlier, Dr. Lloyd was producing a safer product for the patient?
That was not the issue. I wouldn't disagree with that in principle, but that was not the issue which I was referring to.
But it was an issue, wasn't it? Wasn't that an issue that needed to be weighed in the balance against the issue that you have just spoken about, the issue of cohesion and all centres beginning testing together? Would you agree with that?
I would agree it is another view, but on the other hand, and I felt then, and I still feel, that we had an approximation to a national service, in this case, National Directorate, and that we should have followed the Directorate's guidelines. Potentially, that could lead to chaos if we all did things differently.
And what was the concern about that? What chaos would ensue if different if testing is brought in at different times at different centres?
Would it mean that some centres who were not testing would have donors who might say this is unfair because those people up the road have got blood which has been tested, and yet you can't do that for me. That is an argument that could be put forward. I quite agree with that. But I was concerned to establish the screening in the approved manner in accordance with the Directorate's view.
And so for you, it was more important, was it, that there should be cohesion amongst the regional transfusion centres than that the blood donations should be tested for hepatitis C, in some areas several months early?
I've already answered that question.
I wonder if I may ask a question arising out of this. Could we just have the letter back up, please? For
NHBT 5074_03.
if we've got it. It's the last sentence of the second paragraph. I would have thought common sense would have indicated we should all introduce testing for this reagent from the same agreed date. What were the particular aspects that make it common sense? Common sense is a very misused word. It often means thinking as I do, as opposed to you do. So what were the particular aspects of common sense that you thought led to the same conclusion as you were reaching?
Well, this is another example of what had been amiss with the blood transfusion service over the years. But people were doing things differently in different places. There wasn't a commonality. And there were efforts being made, and the National Director was the first step in that direction, to try and get some commonality and uniformity throughout the system, so that we all had the benefit of doing things in a cohesive manner.
So, in effect, the common sense is the same point as the cohesion point.
Yes.
And is it right to understand that in relation to well, I think I'll come back to that point. In fact, if we can see, we can get the other document up that we were unable to see earlier. I'm going to turn now to the question of the arrangements in Oxford for counselling for hepatitis C. And I think the best way to do that is through looking at the documents. Can we look at OXUH 301862 _004? So this is a document, a letter, dear blank, and then if we go over the page, we can see that it's from Dr. Dyke, the Associate Specialist at the Regional Blood Transfusion Service. Dr. Dyke was leading, was she, I believe it's female doctor, is that right? Was leading on the issue of donor counselling for hepatitis C, is that right?
Correct.
And this letter appears to be to a blood donor who has tested positive for hepatitis C as a result of screening of the donation. And so the first paragraph just sets out some background, and then pick it up at the second paragraph, excuse me. I'm writing to let you know that our newly introduced routine test for hepatitis C antibody has given positive results on your recent blood donation. This indicates that you have had an infection with the hepatitis C virus at some time, and therefore might be able to transmit this infection to a patient being transfused with your blood. I'm sure you will appreciate that we cannot accept blood donations which might cause illness, and therefore I regret you will have to remove you from the panel. And then it sets out some information about hepatitis C and the risk to the liver. And you say usually causes a mild inflammation of the liver, or Dr. Dyke does, but a small proportion can become quite ill and have long-term effects. And then you say this: I think we should inform your own doctor of the results, as he may wish to discuss with you the possible need for other tests. I'd be grateful if you could complete the enclosed form and return it to me. Your answers will be treated confidentiality, and the information you give may be helpful in tracing cases of hepatitis and sources of infection. After I have received your reply, I will send your doctor the results of our tests on your blood. I suggest you arrange to see your doctor about a week after you write back to me. And then over the page, your doctor should be able to answer any questions you may have in mind after reading this letter. But if you need further assistance, please contact me. And then again, making the point that they should never donate blood again. So is it right to understand that your practice for those donors that were HCV positive was not to make an appointment at the centre, but to inform them of their infection by letter and seek permission to share the diagnosis with the GP, and for the GP to pick up the baton in terms of counselling and decisions about further treatment?
Yes, that's right. That's fair.
And were you aware that other centres were carrying out different practice, that they were counselling donors themselves?
I was not aware what other centres were doing and had no occasion to ask.
And why was it that you took that route rather than calling the donors in yourself? When I say yourself, I mean calling the donors into the centre and counselling, and the centre counselling the donors, at least initially.
I can't recall what the thinking was behind that, but that was the thinking that we adopted at that time.
And do you know, there was an offer made by Dr. Dyke in this letter to the infected donor to call for further information should the donor want to. Do you know whether or not such phone calls were received by the centre from donors for further information?
I don't know offhand.
And then if we look to complete the picture at the letter then sent to the clinician, the GP rather, if we look at NHBT 00531158, again, we've got another letter here, Dear Blank, from Dr. Dyke, and this appears to be the letter sent to the GP. Your patient is a new blood donor, and routine testing of a blood donation taken on blank is positive for hepatitis C antibody. The donor has been informed of this and has been given this information to bring to you. We have further tested blank blood for hepatitis B, syphilis, and HIV 1 and 2 antibody, and I enclose those results. And then the letter goes on to give some information about hepatitis C and encloses some information about hepatitis C, which the doctor may use to counsel the patient with, and then some information about sending samples to a virologist at Public Health Laboratory Service. So presumably this is the letter, is it, that was sent to the GP if the infected donor gave consent to the transfusion centre to get in contact with their GP?
Indeed.
Going to just ask you a couple of questions about surrogate testing for what was then non-A, non-B. I understand from your statement that surrogate testing wasn't implemented at Oxford on whole blood donations, but it was implemented on, or at least ALT testing was implemented on plasmapheresis donations. Is that right?
Correct.
And what was the reason for that?
Well, the main reason was that we're going to see the plasmapheresis donors much more regularly, much more frequently, and we felt it was appropriate that we ought to try and take a closer look at them for that reason.
Because if they were...
Even though we were well aware that the ALT test by itself is deeply flawed in terms of its relevance to hepatitis C.
But the thinking was it that for a donor that donated, and we saw in a previous document, once a month, more stringent testing should, or some testing even though imperfect, it was better to have ALT testing than nothing at all.
It might help.
And how in practice did it actually work? If there was a raised ALT reading on a plasmapheresis donation, what would happen? Would the donor be deferred? Would it be kept in quarantine? What would happen?
That donation would be quarantined, and the donor would be retested shortly afterwards, well, within the next month. And very frequently, the ALT test might be back down normal or whatever. The ALT was a very unreliable test.
So if the reading was then back to normal, would the assumption be that this wasn't a non-A, non-B, the ALT was raised for some other reason, and the donor could continue to donate, and the donations could continue to be used?
That was our thinking at the time, bearing in mind that there was no actual specific test for Hep C at that time.
And if the ALT reading continued to be elevated, what would happen? If it was elevated in the second test, what would happen then?
We would seriously have to consider removing that donor from the pheresis panel.
And what would the donor be told?
Well, we're told that there appeared to be something which was not quite normal, but we did not know what it meant. It's unlikely to be serious, but we did not know any more details at that time. And subsequently, other tests might be able to confirm a different story, but that's all we could do at that time.
And what impact did the introduction of ALT testing on plasmapheresis donations have on the amount of donations available from plasmapheresis donors? Were many quarantined?
No, they were not. There were very few.
And did that tell you anything about the concerns that had been raised about introducing ALT testing for whole blood donations?
Well, it just raised another unknown, which didn't really help in some respects. It helped only in the respect that, well, perhaps this donor would be put to one side for the time being and then reviewed maybe a few months down the line. But it was, as I said, it was not a reliable test, and most elevations of ALT are due to other causes.
So, given the experience with plasmapheresis donations, i.e. that the introduction of ALT testing had not had an impact on the amount of donations available, was there any rethinking about the position, about the decision to introduce ALT testing and surrogate testing for whole blood donations?
Not really, for two reasons. One is that it was a practical consideration of getting the test actually done. And secondly, once again, we had this question of what was the national policy, what was the directorate thinking, and should we not be following in the agreed pattern of behaviour? And
so, is this right? Even if you had, been a supporter of ALT testing, because of your views on the national policy, you wouldn't have introduced it in any event?
I think that is true. what would have been the obvious thing to do if one had sufficient evidence to be really dogmatic about it, is to go back to the rectorate and say, look, this is the situation which we've found. How about rethinking the national policy?
I'm just going to ask you a handful of questions on hepatitis B.
Well, before you do that, this question of whether to introduce surrogate testing was one which arose before the National Directorate. So presumably you were taking the same approach before the National Directorate itself was formed to the way in which the National Blood Service Transfusion Service was actually operating.
Indeed. We were trying to do our best to treat people in much the same way if we possibly could, even though it was sometimes very difficult.
And part of the reasoning for introducing a greater degree of cohesion was that people were doing different things, to an extent.
To an extent they were, yes.
Yes.
I don't think any other centre had seriously introduced surrogate testing.
Do you know how many other centres were ALT testing their plasma?
I just said, I don't know whether anyone else was doing surrogate testing.
In fact, before we leave the question of ALT testing plasma, can we just look at BPLL 0010787? Sorry, I've given you the wrong reference. NHBT 5077 underscore 092. #5077 underscore 092. Yes, so it's just the first paragraph of that letter from you, your administrator to Dr. Gunson, 13th of March 1990. Dr. Entwistle has advised me that we are going to receive an increased sum for fresh frozen plasma collected by plasmapheresis, which has been alt tested. Do you know why that was?
Well, this follows on from what I was saying just now about doing surrogate testing, such as it was, for pheresis donors. And the fresh frozen plasma collected that way is part of that procedure. So we were aiming to do ALT testing to procure fresh frozen plasma.
And do you know why? Sorry, the question perhaps wasn't very clear. Do you know why a higher price was paid for that plasma?
I don't, except that some people might have thought it was potentially safer. I don't know, but it was. We were getting a better price for it. It's true.
I'm just going to ask you a handful of questions about hepatitis B. NHBT 0081007. So this is a letter from Dr. Dyke to Dr. Barbara, enclosing the annual returns for Oxford's HBsAg positive donors as requested by you. Do you know why that information was being provided to Dr. Barbara? by Oxford. Other than obviously he'd asked for it.
I think at that stage, which was relatively early, it's only 3 years after screening was introduced, Dr. Barbara was very much involved in a program of collecting national data to try and determine what was the exact national prevalence of HBsAg.
So I think it's 3 years after HTLV3 or HIV testing has been introduced, but I don't think it's quite a few years after HBsAg testing has been introduced.
But he was keeping the system going.
And then the second paragraph there, on our computer system, the donor number is more permanent than the donation number. The latter gets lost in the archives once we've clocked up the donation number 999999FN. I've now made sure that all our HBsAg positive donors can be referred to on our computer by their donor numbers. What was the consequence of the problem with the donation numbers? Did that make it difficult for you to trace through donation numbers when you were carrying out tasks like look back?
It could make a difference in time when the donation numbers have exceeded that magic figure of all the nines. Essentially, that is why my colleague had to devise a modification to the computer system to make sure that those suspect donors would be picked up if they came again.
So are you describing there a problem with the computer system, but that Dr. Dyke actually established a workaround, which meant that you could, in fact, trace donors and their donation numbers despite the problem with the computer?
It was obviously imperative that we had to be able to trace them if they turned up again.
So I'm just looking through my notes to see how much longer I've got. I've probably got another 20 or 30 minutes, depending on whether or not we can get those documents back up on the system. I don't know whether now would be a good time for a break or whether it would be...
Well, it depends whether it's 20 or 30, really. If you think it's more likely to be 20, let's go ahead and allow Dr. Entwistle his tea break at 3:30 or thereabouts, and come back with the questions which core participants may have. If it's going to be half an hour, well, let's do it in 2 stages. Have a break now, and there'll have to be a further break later on, Doctor, to allow core participants to to send their questions into Council, and for Council to then ask you what others think would be helpful.
Well, I think 20 minutes, but I'm conscious that I haven't asked some of my questions because the documents haven't come up on the screen. But
well, let's try it.
Well, should we?
Shall we go ahead?
Yes, I think that's because I'm just going to ask you, Dr. Entwistle, now some questions about records. We've looked at the notes on transfusion, and we can go back to that document if necessary. But there's a clear recommendation within that document for reports of transfusion-transmitted infections to be made by clinicians in hospitals to regional transfusion centres. Was that something that the clinicians in your area complied with? Did you get regular and timely information about transfusion-transmitted infections from the blood coming from your centre?
Frankly, no. I've had very few reports of any sort like that.
And why do you think that was?
I don't know.
And did you take any steps to try and improve that situation?
No, I don't think I did. I wasn't even aware that that was a problem. Otherwise, I would have taken steps.
And so how is it that you're aware of that now?
You're asking the questions about it.
So, it may be that, in fact, there wasn't a problem because there weren't any transfusion-transmitted infections. I mean, you just simply don't know.
There were very few that I ever heard of. There was one that I put in my written statement, in fact, which may have been a transfusion-transmitted infection, although it was never finally proved. That's the only one that I can recall.
And again, we can go to the document if necessary, but we looked earlier at the report on record keeping and stock control, the report made to the Department of Health and Social, the DHSS. I think you said you hadn't seen that report before, but in there is a recommendation for blood banks, hospital blood banks, to make monthly returns to the regional transfusion centre. So, for reasons of stock control. So, is that a system that was in place in Oxford when you were there?
Yes, it was.
And so, how did that work? Was it a monthly return from each hospital blood bank? Is that what you would expect?
I think it was nominally monthly, let's put it that way.
So it was supposed to be monthly, but it may be rather less frequently. And what information was supposed to be, and was in fact, as a matter of generality, provided to the centre in those returns?
I'm sorry, what was the question?
What information was supposed to be provided in those returns, and was, as a matter of general practice, provided?
Right. Blood received and blood returned in date if necessary. In other words, could not be used in time, and that was an obvious thing which had to be done.
So you would have a record of any unused blood.
Yes.
And so then you would assume, would you, that anything that had not been returned to you as unused had been given to a patient?
Yes, that's a fair comment.
And did that system work quite well? Was that, as a matter of generality, was that complied with?
As far as I was aware, yes, it was. But as I say, I didn't personally look into the details of that, so I can't answer any further questions on that.
And you, you were the Western Division of the Blood Transfusion Services representative on the Retention of Records Working Party, reporting to the National Directorate. Is that right?
As far as I was aware, yes.
Yeah. And you, there was a piece of work done, is this right, by the Working Party about the number of years that the Blood Transfusion Service should retain their records?
There was discussion about that, but no firm conclusions were ever reached.
So there's discussion about there being a 30-year retention period being appropriate. Is that right?
There were discussions about different lengths of period for it to be retained. And there was also a suggestion that perhaps we should follow the pharmaceutical industry. But then the question was raised, well, why? Is it essential? And I don't recall there being a definitive decision taken as to what the period of retention of records should actually be, or even which records.
And do you recall what sorry, you're going to say something else?
Different periods perhaps could be kept for different records.
And do you recall what the retention period for records in the pharmaceutical industry was?
I think the figure of 30 years had been suggested.
And just in relation to your practice in Oxford, you tell us in your witness statement that the paper donor record cards were kept indefinitely as far as you were aware. Is that
yes.
right? And did you, at any time during your tenure in Oxford, order the destruction of any records?
No, I didn't.
So is it right to say then that during the period of 1980 to 1995, any records that were created in Oxford would have been in Oxford until you left?
They should have been there, yes, either in the written form on donor cards or on the computer records. And that was still ongoing.
And in relation to donors who were found positive for any viral infection, what was the position in relation to their records? Were they held indefinitely to ensure that they didn't come back and donate again?
Correct.
And were there any arrangements for sharing information between regional transfusion centres about such donors to ensure that they didn't, for example, go and donate in a different area?
Not that I was aware of, and neither had we been asked to do so.
Can I just ask you to look at a document we looked at this morning, which is NHBT 306265, which is the 1990 Medicines Inspectorate report. And if we turn, please, to page 9 of that document, I just want to draw your attention to some of the problems with the record keeping that were identified in that 1990 visit. It says, the second paragraph down, the procedure for dealing with donations which test microbiologically positive is inadequate, and goes on to give details. And then skipping the next paragraph down to the records kept in microbiology of the withdrawal and disposal of positive products are totally inadequate. There's no list of the products made, just the donation number. There's no record of the final fate of the packs concerned, e.g. autoclaving or held in the laboratory. The records, such as they are incompletely maintained. There's no procedure for follow-up if packs are not delivered to microbiology. There's no signed receipt given to blood product staff when packs are delivered to microbiology. And then the next paragraph, the flaws in the procedure are highlighted with the case of the SAGM red cell pack in the grouping laboratory fridge. It transpired that the donation had been identified as TPHA positive, but instead of withdrawal and disposal, it had been put in into grouping fridge. In order that a group label could be issued for it, the donation was entered as clear on the computer record. However, although the red cells were held, albeit in the wrong fridge in the wrong laboratory, the effect of altering the computer entry was to enable the plasma to be cleared for issue. Investigations during the inspection revealed that the plasma had in fact been dispatched to Elstree some 3 weeks previously. Steps were taken at the time of inspection to have the pack recalled from Elstree. So there in 1990, there are some quite serious concerns raised about record keeping and so on. I see you shaking your head. What do you say about that?
It was a damning indictment of a totally inadequate situation. And obviously, things had to be done to put things right.
And
We could not go on that way.
how long would you say that that inadequate situation had been in place?
I've no idea. It's obviously something which was recorded at the time, but there's no evidence as to for how long that had been going on or why. But plainly, lack of supervision was very evident. And I plead humble pie for that.
And were steps taken by the centre to remedy the inadequate system that was revealed in that report, in that inspection?
Yeah, we revised the system of supervision in the laboratories, and my deputy, Dr. Marlene Fisher, became overall manager of the laboratory side of things. She was a very bright girl and very efficient, and things looked up considerably after that.
Turning then to hepatitis C look back. Again, we're going to do this via reference to the documents. So NHBT 20873333. So this is a letter from the 21st of October 1986 to to somebody from Dr. Dyke, and it says, "We've been told by the Public Health Department that you have had hepatitis recently. I'm sorry to hear this and do hope you're feeling better now. If you are or have been a blood donor, please will you let me know when and where you last gave blood. I should be most grateful if you could also let me have details of any close contacts of yours who are blood donors." So is it right to understand that certainly in 1986 you were being informed by the Public Health Department of cases of viral hepatitis in your area so that you could do investigations to see whether or not they were blood donors?
This was not a regular feature, and this is an odd one.
So it's not, as far as you can recall, it wasn't a common occurrence that every time there was a case of viral hepatitis, you were informed and you did investigations?
No, as I said, this was an odd occurrence.
And if we turn over the page to page 3, we can see that letter's dated the 21st of October. We can see on page 3 no, I may be having difficulty. I see on page 3 there's a handwritten note the day before, searched, no trace as donor. So it looks like you're notified, you do a search, there's no trace of the person being a blood donor, but nevertheless you write to them to ask them whether or not they've been a blood donor. Does that sound... But I think you've said that this was an odd one. It wasn't something that you think happened regularly. Can we turn then to NHBT 57093 _ 002. So this is a standard operating procedure in relation to transfusion-transmitted hepatitis. And it says there, we can see under addition, it's at the date effective 6th of July 1992, and it replaces a previous one from, is that from 1991? Is that what we understand, that number there, 1003/029101?
I believe so, yes.
Yeah. And so, can you recall whether or not you had standing operating procedures in relation to transfusion-transmitted hepatitis from, well, it certainly looks like from 2001. Do you think that there could have been such procedures earlier than 2001? I mean, 1991.
I would think if it wasn't, I couldn't tell you the precise date when they were introduced, but by the time 91, 92, I would think that is likely. I can't give you a precise date.
So is this fair? There may have been earlier versions, but you're not sure. But 91, obviously, certainly there were. And this seems to deal with the situation whereby you're informed by a clinician that there's been an infection of transfusion-transmitted hepatitis in a patient. And so if we look over at page 2, we can see what's supposed to happen on receipt of paragraph 1. The aim is to trace donors who may have transmitted hepatitis in order to prevent a recurrence, and if possible to prevent any other components of the current blood donation from being used, and sets out there what you have to do on receipt of a verbal or written report that a patient is suspected of having TTH. A full inquiry is to be made. And then paragraph 3, all the blood donations involved must be retested. So just pausing there, can you recall from when the centre started keeping serum samples of blood donations? How far back would you have been able to test?
I can't tell you offhand. I don't recall.
Do you think that was something that was introduced during your tenure, or something that you inherited?
It probably was, but it's a practical detail that I wasn't involved in, and I can't recall when it was introduced.
And then all the blood donors involved must be suspended from the donor panel, and each one is sent a standard letter and questionnaire, together with sample tubes for further tests to be undertaken, or they are asked to visit the doctor. And then if we go over the page to paragraph 6, when all the results of the donors' questionnaires and blood tests and clinical details are known, an assessment is made to resolve the questions: did the patient have the TTH, and if so, which donor transmitted the infection? And letters are written to all donors involved, telling them whether or not they are thought to have transmitted infection, and explaining that they have now been reinstated or withdrawn. And so if we then turn on to the position in 1994, the National Look Back Programme, if we look at NHBT 0055409, and just before I do ask you questions about the National Look Back, in relation to the standard operating procedure in 1991 and 1992, do you know how common it was for look back to be undertaken under those standing operating procedures at Oxford?
I honestly don't know, because I personally wasn't involved in that that part of the centre's activities, and I can't answer the question. I'm sorry.
So if we look then on the 20th of September 1994, there's a handwritten letter from you to Dr. Allah, a re-HCV look back, and you say in the first paragraph, we agree in principle that look back to recipients of blood from donors now found HCV positive is something which should be pursued. The recipients who have survived could be identified and counselled, and some will need investigations and treatment. The scale of clinical involvement here needs to be assessed and the cost of treatment determined and money found. Not easy. Hepatologists should be on board. And if you carry on down, we think around 150 patients may exist on our patch. We don't have the resources at this stage to undertake this extra work. Do you know how you came to the estimate of 150 patients who may exist on your patch?
Yes. Well, we were aware by that stage that the likely incidence of hepatitis C in the population as a whole was going to be a lot less than the number of screen test positives. We know that the screen test positive rate was in the order of 1 in every 200, which means the number of genuine positives is perhaps 1 in every 2,000. And on that basis, we would see somewhere in the order of 1 every week during the first year of screening. So there would be we would have something like 120,000 donors a year, which would mean something like, donations a year, which would mean there would be about 50,000 coming twice a year on average, and about 10,000 new donors in a given year. At the rate of 0.1%, we would see somewhere in the order of possibly 300 or so cases a year. not 150, which is our first guess.
Now,
Now, could you just help me with the figures there? 1 in 200 is a figure of 0.5%, I think. And the rate that you've just quoted is 0.1%. Can you help with what I'm comparing there?
I'm sorry, Sir Brian, can I correct myself, please?
Yes, of course.
I think the figure should read 0.1% screen positive and 0.01 genuine positive.
Very well. Thank you.
Now, the instructions on the national look back from Dr. Robinson were promulgated in January 1995 with further guidance provided in April 1995, and we can look at those documents if necessary. You had an opportunity to look at those prior to giving your evidence. But conscious as I am that you retired in September 1995, given that the evidence you've given so far is that Dr. Dyke was leading, as I understand it, on look back and donor counselling, are you able to help us with the steps that were taken at Oxford in order to comply with the National HCV Look Back programme in 1995 before your retirement?
I hate to have to say this, but I think I must be perfectly honest. The National Blood Authority had instituted independent assessors to look at all transfusion centres and the service as a whole, and this took place during 1994. And the message was coming across loud and clear in Oxford that the Oxford Centre was vulnerable to the possibility of being closed. No decision was taken until during 1995. Now, in the June of 1995, beginning of June, I was summoned to the National Blood Authority premises in Watford, and I was told point blank that the Oxford Centre was indeed going to be, and I quote, closed. So you can imagine that over the course of the preceding months, our attention was not exactly focused where it should have been. And indeed, I was told, as I said, that the centre was going to effectively close. My own personal position was going to disappear, and that is why I opted to take early retirement. And I must be quite honest, I almost lost interest.
And so I think, am I right in understanding the answer to my question is, in terms of can you help us with what steps, if any, given your answer, were taken at Oxford in order to put into place the HCV look back? You're not able to help us with that.
Well, I can tell you something, if I may be allowed to advise you on something which happened after I retired. Is that allowed?
Absolutely, yes.
Dr. Dyke, in fact, who was looking after the HCV situation, did look at the number of people who were positive, identified them, and indeed, but didn't have enough staffing resources to be able to do the appropriate chasing up for look back, going into the hospitals and looking up the patients. She did do that after I retired, when she got some additional help. And in fact, I think she looked at some 350 donors who had been positive. And if I recall correctly, about 2/3 of those were still available and still alive.
So that subject to working out whether I need to ask anything that arising from the documents we couldn't get on the system beforehand, I'll just have a think about that. Concludes my questioning.
Well, it was certainly a lot nearer to 20 than 30 minutes, so thank you. We'll take a break now. Now, you're going to field questions from core participants. Shall we give you till 4 o'clock to do that?
Yes, thank you, sir.
4 o'clock, if you don't mind, Doctor. What happens now, as I've described earlier, is that a number of questions are suggested to Council to ask. I don't know how many that will be. Maybe a lot, maybe a few. But if you come back at 4 o'clock, then Council will ask those questions. It won't then take very much longer, I suspect, but I can't be absolutely certain before your testimony is finished.
Thank you, Sir Ron.
4 o'clock.